webinar on comorbid mental health conditions in veterans, strategies for assessment, case formulation and treatment. And it's being delivered as part of MHPN's inaugural online conference, Working Better Together. A very warm welcome to all of you who've joined us tonight for the live activity. And I should say that we've had around 3,500 registrations for this stream of the conference, the military mental health stream of the conference. And that's an incredible number, and I think it's testament really to just how important this topic is for us as clinicians. Welcome also to those of you who are joining us later on a recording, and of course a very warm welcome to our panel, who I will introduce in just a moment. First, I'd like to acknowledge the traditional custodians of the lands across Australia upon which our panel and our participants are located. And I'd like to pay our respects to their elders, past, present and future. My name is Mark Creamer. I'm a clinical psychologist in private practice and also a professor in the Department of Psychiatry at the University of Melbourne. And I've had a very long interest in the mental health effects of trauma, and particularly in veteran and military mental health. And as a clinician, I am constantly, I guess, struck by how complex some of my veteran clients are, and just what a challenge it is to work with them. And so I'm very pleased tonight to be able to facilitate this panel and to pick the brains of our expert panelists. So without further ado, let me introduce them. You've all had their bios, and so I'll keep it very, very brief. First, I'd like to introduce Kate Howell, joining us tonight from rural Victoria. Kate is a very experienced general practitioner. She's also a therapist, an educator and an author, and has written 5 books on mental health and counselling. She started her career in the RAAF and now works as a GP at Puckapunyal Army Base. So she is very, very well qualified to be joining us tonight. Welcome, Kate. Thank you for being here.
Pleasure.
It often strikes me that we do tend to work in an area that can be quite stressful, so I'm always interested to know what people do to get away from work. What do you do to relax?
Well, I guess I'm a bit more introverted by nature, so I quite enjoy just walking the dog, reading a book, reading the newspaper, having a coffee. But I actually work and live part of the time in Victoria. You'll see the suitcases behind me. I regularly go back to Adelaide, which is my original home, and I live near the coast there, so I catch up with my friends and enjoy the beach.
Right, yeah, okay. So that must be interesting, actually changing location on a regular basis. Every week, I suppose.
No, I actually stay here for 3 and then go back to Adelaide, for a week, 3 days.
Yeah, great. All right. Thank you very much, Kate. Our next panelist is John Finch, joining us from here in Melbourne tonight. John is a clinical psychologist specializing in PTSD. He started his career working with veterans and serving personnel and their families in the VVCS, what we now call Open Arms, and since then has worked with a number of organisations, including Davidson Trahair, Victoria Police and Melbourne University Counselling. He's currently in private practice, specialising in the treatment of people with complex trauma histories. Welcome, John. Thank you very much for joining us.
Thank you.
So let me follow the same theme and perhaps ask you the same question. What kind of things do you do to get away from work and to relax?
Well, literally getting away from work, as in leaving it, is on my bicycle most nights, which helps me just move my attention away from what I've been doing to something else, because you have to concentrate on the traffic to get to the bike path. But then you have a little bit of relaxation, if you like, and sometimes out in nature a bit, depending on which way I go. I always find that that's useful.
Absolutely, I quite agree. That idea of having a very clear break from work, I think, is really useful, isn't it? When I was working full-time, I always used to ride my bike home, and I found it was a great way of cutting off. Yeah. Thank you, John.
Thank you.
Our final panel member tonight is Mary Frost, who's joining us tonight from Darwin. Mary started her career as a GP before later going on to train and qualify as a psychiatrist. In her clinical practice in Darwin, she specializes in the assessment and treatment of serving members and veterans, and of course there's a lot of serving members and veterans in the Darwin area. She's also has an academic position at Flinders University and is involved in teaching medical students. Welcome, Mary. Thanks very much for joining us tonight.
Thanks, Mark.
I should say that everybody here is complaining of the cold, certainly in Melbourne, and I gathered that on the chat room as well people are complaining of it, but presumably you're basking in beautiful sunshine, are you? I don't know you're going to find a lot of sympathy here, but still. Let me just follow up the same question I asked the others, because I've heard a rumor about you. Talking about what people do to relax, I understand that you're something of a musician.
That's correct, yeah. I play a stringed instrument, the viola, and I play in the Darwin Symphony Orchestra. And so through the Darwin Symphony Orchestra, we give concerts, we go on tour. Sometimes we're asked to do small group gigs at places like Government House, and it's a lovely way to be part of a really enjoyable community that I've now lived in for 20 years. So, yeah, it's taken me many places, both within Darwin and within the territory. So I love
That's wonderful. And there is something special about making music with other people, isn't there? I reckon that's...
Oh, yeah.
Yeah. Very special.
Very good for the brain.
Absolutely, yes. Absolutely. Okay, well, thank you very much, Mary. Thank you to all our panelists. Let me just, if I could, spend a few seconds talking about some tech stuff for our participants. We've got a chat box. If you just click on the open chat box, you can post comments to the group there. There's a supporting resources tab, a resources library with a whole range of stuff around tonight's webinar. I would perhaps encourage you not to look at it now, but rather MHPN will send you a link to access all of those resources, and you can go through them at your leisure. There's a technical support tab if you get stuck, for some FAQs there. And we would encourage you, please, in the exit survey to give us your feedback on how you found this platform and whether you like it or not. But for now, I'd like to, I've forgotten to forward the slide to the title, but anyway, you know the title. For now, I'd like to just say something about the webinar series. So this DVA actually commissioned MHPN to deliver a series of 14 webinars on veteran and military mental health. This is the 12th, so there will be another 2 before the end of the year. And previous ones have looked at topics like PTSD and anger, sleep, substance use, and so on. And if you missed any of those and you'd like to catch up on them, they're all available on the MHPN website as well as on the DVA at Ease website, so you can look at them there. But tonight's webinar is looking at the issues raised by working with very complex cases with multiple conditions. And so when we use the shorthand of comorbidities, we're really talking about people who have multiple diagnoses. And we're going to be using a case vignette, Tom, as a kind of jumping off point. You've all had an opportunity to read the vignette, I hope, and I'm sure that it rings some bells for many of you. 2 weeks ago, we talked about Tom as he was just about to leave the military, leave the Defence Force. But tonight we're going to go forward 2 years, and we're going to look at how he's coping now, 2 years down the track, and the issues raised by that. So we'll use Tom's case as a kind of jumping off point. Each of our panelists will give a brief 5-minute presentation from their unique perspective about Tom, and then we'll open it up for a more general discussion and questions, which will take up the bulk of the night. So I think, oh yes, I better just talk about the learning objectives. By the end of all that, we hope that you will, I guess, be better able to recognize the risk indicators, the warning signs, the protective factors for these complex clinical cases, that you'll be better able to describe the evidence-based assessment, formulation, and treatment approaches most effective for this population, and that as a result of both of those two, you'll have more confidence in identifying and supporting veterans with psychiatric comorbidities. And also, I hope that we'll have an opportunity to take it a little bit further and also look at the complexities when we have physical and mental health conditions occurring together. So I think at that point, I will hand over to our first panelist, Kate, to talk a little bit about her perspective on Tom's case from a GP perspective. Kate, I'll hand over to you.
Thank you. All right, so when I read the story of Tom, it certainly, many facets of it resonated with me, you know, both from my experience within working with current Army members, but also as a GP in the community. And I thought Tom might respond to his wife's ultimatum by actually heading off to a GP potentially. Now, he may have stayed away from GPs in the 2 years, I'm not sure, but certainly the GP will need to focus on trying to build a relationship. Potentially that could be challenging given Tom is male and is a veteran, and he's dealing with a whole range of issues on his own and has done so for quite a while. And I'm sure there's a strong influence of a sense of shame for him that perhaps has held him back all the way through of accessing some help and support. I think for GPs and other health professionals, it's really important to get a good understanding of military and veteran health. You know, I spent the day at Whakapanil today, and you know, I saw a man who was very reluctant to access help, and it was a very challenging consult. But I think if we understand to a degree where they're coming from, it helps to respond with listening and empathy. And it will take some time and care, and that can be a challenge in a busy general practice as well. So there's been a lot going on for Tom over a number of years, and the GP will need to try and unpack some of the background and story and the key symptoms and issues, and that may take several consults. Because there are a range of complex issues, you do want to explore what's going on physically for him, physical health and functioning. We heard about musculoskeletal issues, which are a very common problem in veterans, and there may be chronic pain. So certainly before serving members who've been in the military for quite a while, before they leave, we often see that they have chronic ankle problems, chronic knee problems, or hip or low back or neck or shoulders. So it's not surprising Tom's got some issues. But also all the mental health side of things, mood, anxiety, exposure to trauma. We've heard Tom has been drinking more to sleep, irritability with children, anger issues, and you know, just try and explore exactly what's going on in the many facets of Tom's life with family and partner and so on. We want to explore whether there are any social connections or supports that may be helpful, what resources are available to Tom, whether he's aware of any or whether he's tapping into any at this point, probably not. Always a mental state examination, and always want to assess suicidal and homicidal risk, particularly when someone is struggling with depression long-term or PTSD. With reference to the physical illness and the impact of alcohol, you'll be wanting, as a GP, to do some baseline investigations, examine Tom, check him over, check blood pressure, check for any signs of problems related to alcohol, and do a range of blood tests. So that's fairly standard. There is an ADF post-discharge assessment that we can access through Medicare, as well as the mental health plan, which may be a good way to go with Tom and allow some time to thoroughly look at all the issues. Provision of information, you know, is the platform that many of us use at the start of trying to work with a patient or client and trying to gauge what Tom understands, what knowledge he already has, and I guess think in terms of biopsychosocial and potentially spiritual aspects for some people in terms of how issues are caused, but also management. And so education can then lead into looking at what the next steps might be in terms of some help. I think when we talk with Tom, you know, when we read the case, we heard him using quite a few negative statements about himself, that he was of no use, of no value, a loser. And so we need to be mindful of that and supportive and foster some sense of hope within him that he can feel better and that he can contribute to family and community in the longer term. Over time, a GP will hopefully look at aspects of lifestyle with Tom, particularly the benefits of good nutrition and exercise. He's struggling with sleep, so looking at that. And very much looking at small steps to improving lifestyle and small steps with reference to social connection or engaging in some sort of meaningful activity over time. It's very hard for veterans when they leave. You know, they've done a particular range of activities in the military and had a lot of social connection with their fellow soldiers and mates. And to find something in the community that has that sense of purpose and meaning, you know, can be very challenging for them. Part of the process will be referral to mental health practitioners and a psychiatrist for assessment and management. And obviously we have to look at various ways to try and access those services. And again, it will depend on how long it takes to access those services. If we assess that Tom may benefit from medication, we may well start on that process. If we can access further assessment fairly quickly, we may hand over to the psychiatrist that they're saying. But Tom's got quite a few signs that mood is deteriorating, so we will want to get onto things as soon as possible and collaborate with other mental health practitioners. It's very important to make sure safety plans are in place, that follow-up is organised, and that we do monitor Tom for ongoing risk. And, you know, sometimes veterans or those in service can deteriorate very quickly. You know, I've seen people become very unwell over days and need inpatient treatment. So always be mindful that may be needed. Our role may also be in advocacy, assisting Tom to make claims with DVA for treatment support or compensation over time, and encouraging access to resources.
Lovely. Thank you very much, Kate. There's a whole wealth of issues there that I'm sure we'll pick up on in the discussion. Just briefly, I guess that Tom is going to need to engage with DVA, particularly around his mental health claim. Do you ever find that some veterans are reluctant to engage with DVA? Is this a bit of a hurdle for some of them?
For some, yes. For many, they, prior to separating from the military, they will work through the DVA application process with support of DVA advocates and the doctors within defence. But if someone has, I suppose, resentment around the military or anything associated with the military, or, for example, shame around a mental health condition versus a physical condition, that may deter them from making a claim.
Yeah, sure. Okay, thank you very much indeed, Kate. Let's move on now and hear something of a psychology perspective from John. Can I hand over to you, John, to talk a little bit about a clinical psychology perspective?
Okay, thank you, Mike. So from the clinical psychology perspective, we're looking at trying to aim for a good diagnosis for Tom. And what we're looking at when we're looking at this is that we have, sorry, I'm just noticing I'm coming back on here. I was off air for a second there. So when we're looking at trying to aim for a good diagnosis, in inverted commas, a diagnosis that can help us look at Tom's experience and understand it from a clinical and diagnostic perspective, there are a lot of issues that Tom is presenting with that actually could be many things. So we've got things that are depressive symptoms, PTSD symptoms, and anxiety symptoms. And as you can see in the slide, things like anger, irritability, shame, sleep, substance use, his pain as not necessarily a diagnostic category for any of those disorders, but something that complicates the presentation of those disorders and interacts with those disorders, and those disorders interact with pain as well. Things like his relationship and personality factors are all things that we want to consider in terms of trying to understand what is Tom's presentation and how might we best help Tom to move forward from what's going on for him. Now, some of the reasons as to why we might use an evidence-based assessment are that when we're thinking about an evidence-based assessment and someone fitting into a diagnostic category, that's something to do with how we understand that disorder across place and time, in terms of, I could be talking about something like PTSD here in Australia, and in America we'll know that we're talking about the same thing, and that can actually help us inform treatment from different perspectives. Part of that is that we can look at, when we assess for trauma, we are looking at not just the immediate sort of things that are going on for the client in terms of their history to do with the military, where we're also assessing for those things like depression and other things, but their life history in particular for PTSD. We want to know about a range of traumas and whether they are pre-existing traumas. We also want to know about pre-existing issues that might be relating to depressive or anxiety symptoms. Now, some of the things that can help us assess that are screening measures, and screening measures help us understand how someone may fit into a particular diagnosis. And on the slide there, you can see that I've got the LEC5. The LEC5 is a screening measure which actually just assesses all the different types of traumas that people have had. It's linked with PTSD and assessing the number of and type of traumas, whether it's from a natural disaster, military service, whether it's a motor vehicle accident, whether it's sexual assault, which of course all of those things could be traumas that someone in the military could have suffered that are not just specific to the military. The PCL5 is a measure of PTSD that's brief. It's 20 questions just based on PTSD symptoms. The PHQ9 is a screening for depression, 9 short questions, and the GAD7 is a screening for generalized anxiety disorder. And these can help us refine what we might look at when we're looking at someone at their first presentation. And then a structured measure such as the CAPS-5 is a clinician-administered PTSD scale, which is a much longer form of assessment that looks at PTSD specifically, but there are also those for depression and anxiety. And all of this helps us make choices around treatment, and in particular evidence-based treatment in terms of what might work. And evidence-based assessment, when we know, okay, the person may be suffering from PTSD or depression or anxiety, helps us make choices around evidence-based treatment. The evidence-based treatment idea is important in terms of the research helps us understand the effect of the treatment and whether it is effective or not. I like to think of it in terms of most of us might go to our GP, try the medications there, and if we had tried lots and lots of different medications, we might consider alternatives that may not have an evidence base, but we might give them a try to see what happened. The research idea around therapy and treatment and how it works is a significant factor with the choice for evidence-based therapies, in that it will help us. We know a lot about how a particular therapy works when we've done the research. So we know, for example, that in terms of the particular therapy that I focus on, cognitive processing therapy, that if family members support the person to face traumatic memories going through PTSD, that actually the therapy works better. We know that the research around evidence-based therapy also tells us that actually short-term therapies can actually work. We also know that the longer therapy tends to stretch out, that the less effective it is, and that there's more and more research showing with both prolonged exposure therapy and cognitive processing therapy, two of the main evidence-based therapies for PTSD, that the more those therapies are frequent rather than stretched out, the better the outcomes. We also know that the research tells us that men, women, veterans, non-veterans, a whole variety of people will respond to evidence-based therapies. The research is actually showing that. In particular for PTSD, another important factor is that comorbid depression, when treated in the context of PTSD, if we treat the PTSD first, then the depression often shifts as well. So we don't have to focus on one or the other. And that's where that evidence-based therapy and the research behind it is a really useful tool for us as clinicians. Okay.
Great. Thank you very much, John. I think that's your last slide, isn't it?
Yep, that's my last slide. Yep.
I think it is, yes. Thank you very much for that. And I do want to pick up down the track a bit more about evidence-based treatment, because it's going to be central to what we're talking about. But before I do it, I was interested in Tom's comment about somebody owes me. And I'm wondering whether you've got any thoughts about whether or not this is a sort of common attitude, whether it's more typical among veterans than other people, but this perhaps sense of entitlement, not unjustified necessarily, but this idea that someone owes me. Have you got any comments on that?
Yes, I would say that it is not just common to military, but common to what we might term first responders. So we're looking at ambulance, fire brigade, SES, and police members, where they're in a culture where they give a lot, they put their life on the line at times, and part of that culture is that you will be looked after. And so when that looking after is something that is not coming forthwith in their eyes, it can sometimes come across as, well, why aren't I getting what I was promised? And of course, at the same time, you can have some people who actually think they are entitled to these things in a way that might be different to other members within those sort of subcultures, I guess. So yeah, I would very much think it is very much part of that culture, and that you don't find the average person in the street who might have a trauma having that kind of idea that somebody needs to respond. And often they might have that idea if somebody owes them, but at the same time they don't want to accept that treatment. They want to be part of the group, but independent as well.
Yeah, and I do want to come back to that idea of sort of ambivalence about treatment in just a minute. But yeah, look, thank you very much for that. I think it is interesting, and of course, veterans are entitled to a whole lot of services, and we mustn't lose sight of that. It's a question of whether that attitude kind of becomes counter-therapeutic or gets in the way of treatment. But thank you very much, John. We'll pick up on some of those in a minute. For now, let's move on to Mary and see if we can get a psychiatry perspective on Tom's case. Over to you, Mary.
Okay, thanks, Mark. Look, as the other speakers have already touched on, I think we're facing a number of potential diagnostic considerations here. And as a psychiatrist, that's going to be an important part of my assessment of Tom, but also form the basis of treatment. And the 4 areas that I have concerns around are post-traumatic stress disorder. We've heard that he's easily startled, waits at the gym, the noise of waits at the gym. We've heard he's not sleeping well, that his partner is noticing how disturbed his sleep is. We know he's had traumatic exposure about which he doesn't want to talk, and he also speaks of the cry of his children as sounding like triggering memories of time in the Middle East. The depression, I think Kate's pretty well touched on deteriorating mood, sleep and so on. The alcohol use disorder I'm quite concerned about, because not only is it something that he's using to try and numb symptoms and detach himself, but it's also something that is there genetically in his background with his father's death from liver disease when Tom was aged 15. And then the diagnosis of chronic pain I'm not really making because I don't fully understand it at this stage, and that is something that would require me to collaborate with the GP to get better understanding of what's happening from a musculoskeletal perspective. Before I even start to treat Tom, I think it's really important to be aware of the context of his treatment. So we know he lives in a regional town near Townsville. Not that he lives in Townsville, but that he lives in a small town near Townsville. So most treatment is likely to take place in Townsville, which means he's got to get there. There's a scarcity of specialised resources in Townsville, in Darwin, in most regional centres. That means that there's an inevitable difficulty in accessing psychiatric services, which often means that GPs tend to be the primary source of mental health care, with psychiatric appointments being more kind of consultant, having a sort of consultant rather than treatment role. And obviously, if he's not working, his wife is, and he then has to start travelling regularly to Townsville, then that's going to make demands on family life, which needs to be taken into consideration. Sorry, my mouse just won't let me. Yep. Okay, so thinking in a broader sense about Tom's presentation, I fall back on a formulation and think about things like biological, psychological, social contributors to his current predicament. I'm concerned about his father's death from alcohol use when Tom was aged 15. I'm concerned about Tom's own alcohol use, his pain and physical disability, and whether or not he's using analgesics, either prescribed or non-prescribed, although these days with prescriptions for over-the-counter codeine being less available, that seems to have diminished some of the role of unprescribed, non-prescribed analgesics. I do wonder, we don't know a lot about Tom's background, but his father died when he was aged 15. His mother died a few years later. Does he actually have a trauma history in that setting of family dysfunction, his father's unavailability, his mother's perhaps submission to a drinking dad and walking on eggshells, as I hear from a lot of my military members. And so Tom, as a young man, decided that he really needed a different kind of family. He was seeking a father figure, and he joined the army. He then also kind of attached himself to his partner's father, Bruce, and now feels that he's failing Bruce. And so that's a significant loss. He's already lost his own dad, and now he feels like he's letting his other father figure down, having lost his family, the army. And he talks about he was a hero and now he's a loser. So there's this considerable loss of role and identity and grief. I'm also concerned, as is very often the case with veterans and military members, that their reluctance to seek help characterises a lot of their psychological battles, or else they come in the throes of a marriage that's about to end, at which point you're not quite sure of their own motivation for help. We know that he's isolated, he's living remotely. I'm concerned about Sonia's mental health. Again, we don't know much about that, but she has been prescribed sleeping pills. He's using her sleeping pills. He's very detached from the family. He worries about the children's crying. Sonia's clearly indicated that she's finding him tough going. And the in-laws, which previously were a source of great support for him, he's also distanced himself from. And in that setting, suicide starts to become a real concern for me. So, you know, in thinking about safety, I'm thinking about Tom's safety, his risk of suicide. I'm thinking about his anger and the children and Sonia. I'm worried about his alcohol consumption and possibly his use of analgesics, illicit substances and so on. And then the physical comorbidities, which I'll leave, Kate covered those well earlier. So like Kate, I think the Therapeutic Alliance is slow, cautious, and requires a lot of patience on the part of the practitioner, because he's told us he's ambivalent about treatment. He's told us he's reluctant to attend. So I think if we impose a model too prematurely on Tom, he'll run. So, you know, sometimes in this setting, and I think there are a variety of approaches, if Sonia is the one that's declared the ultimatum to his help seeking, then I might start fairly early by involving her. Sometimes reminding Tom of his desire to be a good father figure means that I sort of establish the Therapeutic Alliance by reminding him of being a dad, and there's a lot of mention of the children. And sometimes in veterans, they become the primary caregiver, and I actually meet children, they come to appointments. So the children can sometimes be a way in. As Kate's already mentioned, there are a number of symptoms that need to be targeted. And she and I, the list we have is virtually identical. And I don't want to go a lot into biological treatment, but I think it's important to mention that benzodiazepines shouldn't be used because this is a fellow that's already drinking excessively. That the evidence around SSRI antidepressants is mixed, but is probably there. And there are a number of other agents used in the treatment of PTSD, which I won't go through. The final and I think most important thing in the management of Tom is the need for collaboration. He has complex comorbidities, and if he were in the military, I would indirectly be knowing about his musculoskeletal status through a physio. Not that I'd be contacting the physio, but I'd be hearing from the GP about what the physio thinks about his musculoskeletal status. So that's the sort of level that I think as a psychiatrist I need to have some awareness of the complexity.
Thank you very much indeed, Mary. And again, a whole lot of points that we'll pick up on in the course of our discussion there. But I would like to just touch on that last point. And you kind of ended slightly more, perhaps more optimistically than I would. This idea of the importance of us collaborating amongst ourselves as professionals around a particular case. Do you think we're generally reasonably good at that? Or do you think it happens?
Look, I think it depends on us individually. Some of us are, I think, by nature collaborators, and some of us tend to sort of row the boat a bit as a solo oarsman. But I've always really enjoyed collaboration, and I think working in a multidisciplinary setting, which I can't do as a private psychiatrist, means that I actually reach out a lot to particularly the psychologists that also treat the patients that I'm seeing, and the GPs. And without that, I feel much more pessimistic about treatment. But I think when others are contributing, it makes me feel that there can be some kind of like division of the pie, and I can focus on this area knowing that somebody else is monitoring analgesics or checking liver function tests in the case of alcohol. So yeah, I think it's really important.
Yeah, I certainly agree that it is very important, and I'm just not sure that it always happens as much as it should, but I certainly agree with the importance, and it's up to each of us, I suppose, to make sure that we do communicate and don't necessarily wait for others to contact us. Anyway, thank you very much, Mary. Thank you indeed to all our panelists for those presentations, very enlightening. I'd like to now kick off the broader discussion, and I'm going to invite the panel members to just jump in and add alternative perspectives or disagree if they want to, but I will direct questions at each of them. And I should say that I've been very impressed by the number and the quality of questions that we've received from the participants, and indeed are continuing to receive. And we will try to get through as many of those as possible, but we have very limited time, so please bear with us if we don't get to your particular question. But let's kick it off with something that I think all our panelists mentioned, and I'm going to turn to you, Kate, if I could, to start with, because you made a particular point about the importance of engaging Tom in a therapeutic relationship and some of the challenges that might bring up for you. So I guess, yeah, I'm wondering really whether you think it's more difficult to engage veterans in treatment than it is other populations. Kate?
I think it varies. Certainly with Tom, it sounds like it would be, you'd have to work fairly hard and make sure that you get him back. Sometimes a thing that helps me is sort of looping back. If I'm finding a bit of a resistance, or he doesn't want to talk about something, putting it on the shelf in my mind and coming back to it later. It might be later that session or later in another appointment. But certainly there's a lot more openness in the military around mental health issues, for example, and a lot more support than in years gone by. So a lot of people who are leaving the military have already had treatment for mental health issues, have accessed DVA, etc. So it is a bit individual. You will always get those individuals who perceive that a mental health issue in particular represents weakness, and their concern is that other soldiers will put them in the basket of, that soldier's broken because they're weak. And they're not my words, they're words from soldiers I've worked with.
Yeah, absolutely. And certainly there's a clear ambivalence, I guess, with Tom, which is perhaps born out of that military culture in part, perhaps, and also part his own personality. I guess I'm wondering whether, well, perhaps I'll move on to John. Do you, John, have any tips for us about how you would go about engaging someone like Tom in treatment?
In terms of someone like Tom, things like knowing the military language can be really helpful. Where he has a sense of this person understands him. So you can find lists of military language. Knowing something like what a grunt is, for example, might actually, which is an infantry soldier, might actually help engage Tom to see that you understand some of his perspective. A time sort of factor is also often part of the situation, and also, I guess, engaging him in his motivation. What are the reasons? Okay, there's the ultimatum from Sonia, but also he's chosen to come in himself rather than just ignore that ultimatum, and that working on with that motivation and building that can be a really important factor, as well as helping him to understand what the options might be in terms of treatment. And that doesn't necessarily have to happen straight away. You can build some trust first, but once he does do something, he can actually have change as well.
Yeah, yes, absolutely, absolutely. Okay, so let's assume then that, sorry, that Tom has turned up for treatment. I wonder, Mary, if I could turn to you. You did comment a bit about some of the things you were worried about. I wonder if we could just have a bit of a general chat, both in Tom's case and more generally, about what you think are the red flags. What are the kind of warning signs that someone might actually be perhaps on a downward spiral or heading for something fairly serious? What kinds of things concern you?
Well, in the case of Tom, I think we know that his mental health considerations are actually quite, I won't use the word chronic in a sort of chronic psychiatric patient setting, but meaning that some years ago he acknowledged that his mental health was compromised and agreed to seek counselling but didn't. That in itself is a red flag, that it got to a point where he accepted the need for help but didn't follow through, and now is following through with possible reluctance or at Sonia's insistence, or maybe he's there, as John has said, because he now wants to be. So the actual engagement is itself a red flag. The big one is his social isolation. I really worry about, Kate was talking earlier about the sort of the family of ARMY, the number of peer supports, the number of mates that serving members have that very quickly drop off the radar once someone is discharged. He's living in a remote town, he's not working, he's disengaged from family, he's drinking, he's possibly using analgesics, and virtually nothing that's given him meaning or satisfaction is currently working for him. One of the ways I sometimes engage with my veteran and military patients is through their fitness. And so I ask them a lot about their physical capacity and their regime at the gym, and then talk to them about how that physical discipline we can use the same discipline in a psychological sense. But when I hear that somebody has stopped going to the gym, or they're going erratically, or they're hardly going at all because they don't like crowds or they don't like the noise at the gym, then that to me is a red flag as well, because these are guys who've always prided themselves on their physical prowess, and that very act of being a strong, tough soldier has formed such a huge part of their identity that many of them try and retain once they leave the military. And so when they start to lose that, that's another red flag. And then obviously asking the usual questions about suicidal thoughts, suicidal intent, suicidal planning, protective factors. In his case, I think the protective factors are probably Sonia and the children, but I'm not really sure what other protective factors there are. And if Sonia were to leave him, I think that would be, I concur with Kate, that sometimes a shift in the social dynamic, like losing his relationship, can suddenly mean somebody's at high risk of suicide, and then I would be thinking about inpatient management.
Right, yes, absolutely. If I could turn to you, Kate, because very often the GP is, of course, the, well, it's kind of the linchpin, perhaps the case manager, for want of a better word. And you talked about the post-discharge mental health assessment. My understanding is that there are plans to increase that. I'm not sure if you're aware of that, or whether it's been announced yet, or I just heard. Have you heard of plans to increase the number of sessions available to GPs for assessment?
I have heard about it. I haven't gone on a search to confirm that, so I probably can't exactly answer that. But
I'm not sure that it's gone live yet. I'm not sure that it's been launched. I think it's imminent. Yeah. Yeah,
but certainly the assessment, and also utilising the Medicare mental health plan, it at least provides more opportunity, and the post-discharge assessment is very good in that it's quite holistic and looks across physical well-being as well as mental health, pain, a whole range of issues.
Yeah.
So, it's certainly worth tapping into.
Absolutely, absolutely. Well, just picking up on one issue that we might want to do some assessment on, and you mentioned particularly about the importance of meaningful activity, which I 100% agree with. So in a case like Tom's, how important do you think it is to get him a vocational assessment, and to be looking at perhaps some kind of employment opportunities, even if they are very low-key? Is that an important thing for someone like him?
I think it will be important once he's on the path to recovery. It may be a bit early at this stage, but before I was a doctor, I was an occupational therapist. So I'm very, I'm very into activities, and it may be that again you have to start small and find out from him what has been meaningful in the past. And as Mary said, it may be well related to fitness. It may be something else. We don't quite know. But looking for some opportunities based on what he says has been meaningful to him before, or sometimes reconnecting. It may be meaningful for him to reconnect with other veterans through RSL, etc. So, part of it's just going to depend on discussion with him and what you identify. And I suppose you want to set him up for success by starting with small, brief activities.
Yes, absolutely, absolutely. And I would like to come back to some of that stuff later. If I could turn to you, John, though, as part of the assessment, how good do you think we are at actually asking the person, the veteran, if you like, what their goals are, rather than kind of the formal assessment that you talked about? Do we also need to be asking them what they want out of treatment, what they expect out of treatment?
Absolutely, yes. We need to really look at how our treatment might move them towards what they want. We're not going to go anywhere if we're not working on that. And being able to identify that is a really strong key to people's success, and is often a challenge in that they might meet a criteria for something, but that's not what they understand their experience. And in terms of not understanding the experience, they might not understand how that may impact on their life. For example, most often people present to me with a relationships kind of issue that is actually part of a previous trauma, and it's a job for the clinician to integrate. Well, they want their relationship to be better. What are the things that are affecting them, and what are their goals with that relationship? So understanding that side of the person's experience is a really important part of why they come in to start with, but also their success, and understanding that I'm withdrawing from things, I'm finding the kids irritable, but I don't want these things. Well, what is it that's driving those?
Yeah, absolutely. And I guess, Tom, well, certainly like so many of the veterans that I've come across over my career, is primarily presenting for treatment, not necessarily because he particularly wants to, but because his wife has said she's going to leave him if he doesn't. So he's being pushed into treatment for specific reasons. So I take your point that how important it is to really work out, to come to some collaborative agreement, I suppose, about what we need to work on in treatment. Yeah. Okay. Tom is presenting with a whole range of mental health conditions. That's the nature of our talk tonight, is about comorbidities. And obviously we don't have time to go through them all. I would recommend to you actually that you do go back, if you would like to look at the treatment of specific conditions like PTSD or substance use or whatever, that you do go back and have a look at the earlier webinars. But I would like to pick up on a couple, and one that I'd like to start with actually is anger, because I think that anger often gets in the way of treatment. And perhaps if I could come to you, Mary, first, and just pick up on something that you said about safety issues. How concerned do you think we should be, Mary, with, I guess, with safety issues of his family, of Tom's family, for his wife and children?
Look, I think there are a number of red flags in relation to the safety of his wife and children. And one is Tom's withdrawal. So Sonia's kind of almost said to him she doesn't want him in the bedroom. He's another child. He's a burden. She's already got 2 children. She doesn't need a third. She's spending more time with her family, and they've offered to have her live with them. And so I suspect that Tom's anger and irritability is really driving a major wedge between himself and his family. And for him, kind of developmentally, that's really significant, because he was a fellow who lost his dad quite young, lost his mum a few years later, joined the military. So this notion of his own family is I would suspect, a very strong value to him. And, you know, when we're talking about engagement and what are his goals, I suspect one of his goals would well be to re-engage with his family and to preserve his family. So I think he's trying to help him manage and modulate and modify that anger is going to be a critical part of therapeutic alliance. In saying that, I don't think that psychiatrists have a lot of very helpful medications that specifically just target anger. I think we target arousal, anxiety, and then sometimes people say that that makes them less irritable, but it's almost as if that's a kind of spin-off from modifying anger. So, sorry, by reducing arousal, it makes people less angry, but I don't think it's a direct effect on anger. I think most of the medications that psychiatrists have that make people less angry are actually very sedative, and then people complain of feeling like a zombie. And that's not helpful either, because when you're a zombie, you don't go to the gym, you don't interact. So, yeah, I think that's a very fine balance from a biological perspective.
Absolutely, I quite agree. But let's turn, if I could, to non-biological, and perhaps bring you in, Kate. I wonder whether you have any, I don't know, any tips for managing angry patients in the consulting room, perhaps for clinicians, and or perhaps what you might be saying to families about how they can, I guess, de-escalate the anger at home and so on. Do you have any tips or strategies for people there?
I think, you know, in terms of in the consulting room, we, you know, in the first instance, we have to be mindful of our own safety as well as the safety of the patient. And, you know, earlier today I was concerned about someone who was escalating and in terms of their anger with the situation, and I actually brought the consultation to a close. It was appropriate to do so, but I thought I just need to sort of contain this by bringing it to a close, and took him out to make the next appointment and to organise an appointment with the psychologist. So I sort of changed I didn't let it run on and on. I mean, obviously us remaining calm, and I think too, military members are used to people, you know, even though you're there as a therapist or a doctor, you still have a degree of authority, and I don't use it often, but occasionally, you know, you need to be clear in your communication and say, look, this is not okay. We need to calm down, take some breaths. Let's just sort of settle things down so we can talk more, and actually use that bit of authority to contain the situation.
Sure. And I guess setting clear boundaries about what is and is not acceptable behaviour. Yeah.
And I suppose with family as well, it's you know, the usual sort of psychoeducation about what's reasonable and what's not, and strategies such as taking time out, or breathing, or counting to 10. You know, I did have one couple who used the stress bucket metaphor, so that they talked about their own stress bucket, how it was building up, and when they were near the top, they could communicate to the other person, look, my stress bucket's really full, I need to just sort of work on getting that down. So they were able to share that between them, both of them.
Yeah, okay. So having a shared language to kind of communicate about that issue, I think is a very good idea. Just while you're there, Kate, we've had a few themes coming in on the chat box, and one of them has been a concern that there are long waiting lists for veterans. It's probably hard for you to comment because it depends so much where you are, I suppose, geographically. But do you think that long waiting lists for veterans to get help is a problem?
You know, it certainly can be. It depends a bit on the area. You can, you know, try and prioritise the patient if you're really concerned. But yes, I presume this is in relation to open arms or psychiatry or private. Yes,
exactly. I think but all of those.
Yeah.
So yes, okay. So it's the way it is, I guess, and yeah, hopefully the waiting list is not too long.
Right, and as Mary was saying, some regional areas there aren't too many services. I suppose something to always bear in mind is are there phone services available either through various agencies or with private psychologists, for example, or telehealth psychiatry.
Yeah, yes, quite. Okay, let's go on if we could and talk a bit about specific kinds of treatments. And as I said, we clearly can't go into detail about all the available treatments for multiple conditions, even just for PTSD, actually. But I wonder if I could start with you, John, and ask you literally just to give us 1 or 2 sentences and really no more on the key sort of evidence-based treatments. And I suppose I'm thinking CPT, which you mentioned, prolonged exposure, maybe EMDR, just 1 or 2 sentences to orientate people as to what they are.
Okay, so they're all therapies that have a lot of research behind them, which means we know that they do work. We know how well they work. We also know the factors that make them work. They're all relatively short term. They're not years and years. They can be completed in a matter of months. And on average, about 2/3 of people will come out of that without a diagnosis. And we know that there also is work being done because of the research to actually look at what factors can be tweaked, if you like, to try and improve outcomes. So I guess evidence-based therapies have lots of support, and there's ongoing research, I guess, and that helps us understand how they work and what factors sort of improve or potentially make them not work as well, such as the more we space out sessions, for example. We know that that doesn't work.
Yeah, and so really to emphasize the point I think you really made in your talk, which is that everything else being equal, these really should be our first-line treatments in something like PTSD, would you say?
Absolutely, absolutely. And I suppose in terms of just short, brief, how they work, we know that all of those treatments work by stopping avoidance, which is the key PTSD symptom.
Yeah.
And they deal with that.
Yeah, okay. Cognitive and behavioural avoidance, I guess we're thinking.
Yeah, in all its forms. Yeah.
In all its forms. Okay, thank you, John. Mary, if I could turn to you and talk about meds. You spent a bit of time, well, you mentioned very briefly some of the medications you might consider. I guess I'm wondering what might be your, I guess I'm assuming probably that perhaps an SSRI or similar might be one of the first line. Would that be right?
Yes, that would be correct.
Yeah. And I wonder if you could comment on, I guess, the side effect profile. And I'm thinking particularly about the impact on weight gain, perhaps, but also sexual dysfunction, and particularly for someone like Tom, where we might get erectile dysfunction as a side effect of SSRI.
Sure. Look, I think one of the difficulties about the assessment of sexual side effects and antidepressants is that often the first time somebody reports sexual dysfunction is after medication has been commenced. But when you take a history of the sexual dysfunction, it actually predated the prescription of antidepressants. And somebody who's feeling ashamed, who's lost identity, who's feeling less powerful in a relationship will often have sexual dysfunction as part of that. And that's not to avoid that. I mean, there is a very definite link between sexual dysfunction and particularly SSRIs. There are a number of newer antidepressants which are less likely to cause sexual dysfunction. There's an antidepressant that's come onto the market in Australia in the last few years called vortioxetine, meclobamide, which has been around for some years, agomelatine. But I don't think in the case of agomelatine or meclobamide they really have a strongly established evidence base in the treatment of PTSD. But nevertheless, I will sometimes change patients from an SSRI to one of those other agents. Weight gain is generally less of an issue on the SSRIs, although I think, again, there's inter-individual variation there. Weight gain tends to particularly happen with the atypical antipsychotics such as quetiapine, which is prescribed quite commonly to treat nightmares. there has been some work in the last 10 years to do with non-psychotropic agents having a role in the treatment of arousal and nightmares, things like clonidine, prazosin. But again, I think the evidence base is not firmly established. But nevertheless, I will sometimes use those medications where somebody's been intolerant of the psychotropic agents and trial them on the non-psychotropic agents to see if that reduces arousal. But that requires quite a lot of monitoring, particularly of blood pressure with prazosin and clonidine.
Yeah, okay. It's a complex issue, isn't it?
Mm.
And to turn to you, Kate, if I could, you mentioned a number of things, I guess relatively quickly, but things that I think are crucial. But I wonder how important you think they are. I mean, I guess I'm thinking about more lifestyle kinds of things, social engagement being a big one, but also things like exercise and diet and rest and so on. How important do you think these things are in someone like Tom?
I actually think they're really, really important. So, when we eat well, when we get some sunshine, when we exercise a bit, when we engage with people, it has a very positive effect on mood. And a lot of those things will drop out of the person's life as they feel worse. So I actually have what I call a wellbeing script, and I go through it with people, and I've typed it all up, and we can write on there where there perhaps some changes can be made, and from there then go to some basic goal setting. And I find people respond to that really well, so making it very meaningful and concrete.
Yeah.
So, yeah.
I absolutely agree. I think that things like that can make a huge difference, and yeah, re-engaging, enjoyable activities and things like that. And I think, I do think sometimes that we as clinicians sort of get involved in very high-level therapies, and we think they're really great, and it's and we sometimes forget about these things that are actually so important starting points. Lay that basis. I'm often struck by as I understand it, the literature on depression that says, behavioural activation is far and away the most important thing. Get people doing things, so basic kind of stuff.
A couple of recent examples, a woman with anxiety, lots of issues. But when we went through that script, she was drinking 2 litres of Coca-Cola every day. And, there's a lot of caffeine and sugar in Coke. And, she actually felt a lot better when she changed what she was drinking as her main fluid. Someone else who's, depressed, someone like Tom, if he actually manages to get out and walk the dog around the block in the sunshine or get out into nature, Townsville, there's some beautiful spots, go for a walk along the seafront or something, take the kids, it may well do a lot of good for his mood.
Absolutely, absolutely. And we've got a mounting body of evidence, haven't we, around the benefits of physical exercise generally in mental health. While I've got you, Kate, and we are running out of time, we've only got a few minutes left, so very briefly, and I know it's a big issue, but would you want to involve Tom's partner in treatment? Should we be involving his partner?
Yes, very much so. I think, it says that I'm presuming Tom goes to the GP. He may well go with Sonia in the first instance. It's not uncommon for a husband and wife to turn up, or partners to come together. And so, it's important to see Tom obviously on his own as well. But for Sonia, information is important, understanding what's happening for Tom, obviously with his consent. But also she may well need therapy as well and support. And so it may be that she needs to see her GP and, perhaps see a therapist herself or a counsellor, or, get some of that support as well.
Absolutely. And I think it is an interesting, I was going to say dilemma, that's not the right word, but how much we're seeing the partner so that they can help the veteran, and how much we're seeing the partner actually because of problems that he or she has. But Yeah, good point. Okay, final question before I begin to wind things up, and I might chuck this one at you, John, if I could. We've talked a bit about the lack of, well, the difficulty, I guess, in rural and remote areas of getting access to treatment. John, do you have any suggestions about what we can do in terms of perhaps online internet-based treatments? Have we got any evidence that they are helpful?
We do have evidence that they are helpful, and in particular, I guess, cognitive processing therapy. I must declare my bias. There's a number of research studies done in the US that show that they actually have equal outcomes to face-to-face counselling, and in fact, even in groups done on the internet, which I find really surprising, but even in groups done on the internet, they have outcomes that are the same, and they also have better bonding across the internet, which one with my biases about that,
isn't it? Yeah.
It seems to be, but yeah. So yeah. There is research that shows that it can work, and certainly from what I know of the US context, which would be very similar here, it was developed in the US because of those difficulties for people in rural and remote areas.
Yeah, so that is very encouraging. But just to be clear, there you're talking about a therapist working online through Skype or something like that. Is that right?
Yeah, absolutely. There's not much evidence in terms of somebody doing a sort of structured program that might be like an online education program. Having that opportunity to get feedback from a therapist and understand the experience and understand where your kind of beliefs go that have been changed through traumatic experiences is something that the therapist is a key for that. Yeah.
Absolutely. Still, no doubt we will continue to see a growth, I guess, in online and technologically based treatments. But alas, we're running out of time. We really only have a couple of minutes left. And so I would like to, if I could, ask each of our panelists whether they have one or two take-home messages that they'd like to leave our participants with. And perhaps if I could start with you, Kate, is there any final messages you'd like to leave our participants with?
I think holistically. There's my dog in the background making an appearance. So, you know, people have all sorts of aspects to their lives. So, you know, think about all of the problems, but also think of all the many facets to Tom's life. And I think, you know, if you can create a team around Tom, that's going to be most helpful.
Great. Okay, thanks for that. And it's very nice to see your dog wandering around in the back there. John, any take-home messages from you for our participants tonight?
I guess the take-home message for me would be that you know, the evidence-based therapies are really good. They work very well, and the key that they have is that they are trauma-focused, and that's a really important thing. And I guess in terms of thinking about the holistic thing that Kate has mentioned, the holistic idea, we might be engaging with the GP, with the psychiatrist, helping the client move towards an evidence-based treatment that's trauma-focused. It can be a difficult thing to think about to start with, but if a team is there, that can be helpful. So interacting with your team for the veteran is good, and evidence-based therapies have that edge in terms of that trauma focus that helps people change things significantly.
Lovely. Thanks, John. And Mary, any final take-home messages from you?
Yeah, look, I think I'm just endorsing the messages of the others, but it's really kind of the C words: collaborate, communicate, and care. And I think sometimes we open this discussion around entitlement, and sometimes the Toms of this world can have a very abrasive quality that puts us off and makes it hard to care for them. And so sometimes finding your way in and finding the sort of, you know, the softie, the marshmallow inside can be really helpful to then be able to better care for Tom, as well as obviously the collaboration and communication.
Great. Thank you. Thank you, Mary. Thank you very much to all of you. Look, I've just got a few very quick closing comments to make. First of all, a reminder to everybody that MHPN runs local networks, and in particular, a number of networks that are specifically oriented towards veterans' mental health. So for more information about those, you can join a network, or indeed, if you'd like to start one, do contact MHPN. A reminder, as I said at the beginning, that there are a number of resources to go along with this webinar tonight, and MHPN will send you a link to all of those resources so that you can access them. But for now, it's really time to sign off and say thank you. I would ask you please to make sure that you complete the feedback survey before you log off. But basically, thank you very much to everyone for what I thought was a great webinar. This is the last activity in this particular stream of the MHPN online conference, and tonight's activity will be up on the website, I think, in around 24 hours. So thank you very much to MHPN, to DVA, and to Redback for their support of this and other webinars in this series. Thanks very much to our panel tonight, to Kate, to John, and to Mary. And thank you very much to all of you participants for your involvement and engagement in the webinar. Thanks very much, and good night to everybody.